Imagine beating cancer. You endure the grueling treatments, you finally, get to ring that bell in the oncology ward, and you get your life back.
Right.
Only when you step back into that life, you realize the treatment has left you with this daily agonizing physical pain that no one really warned you about.
Mm.
And worse, standard medicine seems almost afraid to treat it.
Yeah, the narrative of surviving cancer is heavily sanitized, I think. We focus entirely on eradicating the malignant cells.
Which is obviously the priority.
Oh, absolutely the priority. But the collateral damage to a person's long-term daily reality, it just gets pushed to the margins. It becomes this massive medical blind spot.
And if you are listening to this right now and you've navigated life after breast cancer, you already know we aren't talking about a minor inconvenience here.
No, not at all.
So we are dedicating this custom-tailored deep dive to a highly specific, cutting-edge medical question that lives right in that blind spot. Our mission today is to answer this. Can dehydrated human amniotic membrane allografts safely promote tissue remodeling in cases of refractory post-cancer dryness?
It is a phenomenal question. I mean, it forces us to sit right at the very messy intersection of oncology, gynecology, and experimental regenerative medicine.
To give you a real answer, we have pulled together a stack of sources that cover all those bases.
We've got quite the variety today.
Yeah, we are looking at official medical guidelines from the British Menopause Society, clinical FAQs and guidance from the Women's Health Clinic, and some incredibly dense technical research papers that map out the biological properties and surgical applications of human amniotic membranes.
And synthesizing this material is crucial because, well, there is a vast gulf between what works in a laboratory setting, what is successful in a major surgical theater, and what is actually proven to be safe and effective in your neighborhood outpatient clinic.
Okay, let's unpack this, because before we can even begin to evaluate if amniotic allografts are the miracle solution here, we really need to understand why this specific type of post-cancer dryness is such a massive, stubborn hurdle in the first place.
Right, we have to establish the biological baseline.
Exactly.
To understand why patients are seeking out such extreme innovation, we have to look at what breast cancer treatments actually do to the body's endocrine system.
The hormones.
Exactly. Whether a patient undergoes chemotherapy or the surgical removal of the ovaries or takes long-term hormonal therapies like tamoxifen, arimidex, or aromasin.
The aromatase inhibitors?
Right. The primary physiological goal is often to drastically, systemically drop the body's estrogen levels.
Because in many breast cancers, estrogen is essentially the fuel that feeds the tumor. The overarching oncology strategy is to cut the fuel line so the cancer starves.
The problem is that estrogen isn't just fuel for a tumor. It is the crucial systemic hormone that maintains the structure, the moisture, the elasticity, and the blood flow of the vaginal and vulvar tissues.
It's doing a lot of heavy lifting.
It really is. So when you suddenly and severely cut off that estrogen supply, you trigger a cascade of structural deterioration. It's known as genitourinary syndrome of menopause, or GSM.
I think the word dryness does a massive disservice to what GSM actually is. I mean, it makes it sound like chapped lips.
It is a complete misnomer. Without estrogen, the tissue undergoes severe atrophy. We're talking about the vaginal mucosa literally thinning out on a cellular level.
Oh, wow.
Yeah, it loses its elasticity. The glycogen levels plummet, which causes the naturally acidic pH to rise.
And that rise in pH is bad news, right?
Terrible news. It kills off the healthy bacteria and invites chronic infections. And the natural lubrication mechanism just completely shuts down.
Which leads to the symptoms.
Right. The result is chronic pain, intense burning, and severely painful intercourse that can make physical intimacy basically impossible.
Given how severe that sounds, the standard over-the-counter moisturizers you see at the pharmacy can't possibly be enough to reverse it.
They absolutely cannot reverse it. Let's look at the non-hormonal options available. You have moisturizers, often containing hyaluronic acid. These are generally considered safe for oncology patients, and they do provide temporary relief by pulling moisture into the area and, sometimes lowering the vaginal pH temporarily.
I was thinking about this while reading the sources.
Yeah.
Using those moisturizers feels like taking a bucket of water and pouring it onto dry sand.
That's a good way to put it.
It gets wet for a moment, and the friction is gone temporarily. But the actual structure of the sand hasn't changed. The second that water evaporates, you are right back to a dry, harsh environment.
That is a highly accurate way to visualize the cellular reality. Non-hormonal moisturizers are purely symptom management, They do not reverse the underlying cellular architecture that has been degraded by estrogen deficiency.
They offer zero structural repair.
None at all.
But then if you look at the treatments that do offer structural repair, the hormonal treatments,
Hmm.
you walk straight into a minefield of anxiety. I'm talking about things like low-dose vaginal estrogen creams or DHEA suppositories.
Those treatments are incredibly effective for the general population because they actually reverse the cellular changes.
They fix the sand.
Exactly. They replace the missing metabolic signal and tell the atrophied tissue to rebuild its thickness and elasticity.
So if the moisturizer is just water on sand, the hormonal creams are like fundamentally changing that sand into rich, fertile soil. It's highly effective for growing healthy tissue.
It is.
The obvious terrifying catch is that if you've just spent years fighting a hormone receptor-positive breast cancer, changing that soil is incredibly risky if it might also grow a weed.
Meaning a recurrence of the cancer.
Right.
That anxiety is the core of the dilemma. The British Menopause Society guidelines provide a very nuanced take on this. They state that for women with a history of breast cancer, the systemic absorption of low-dose localized vaginal estrogen is incredibly small.
So the risk is tiny.
They say the risks are generally absent or negligible, but they heavily emphasize that prescribing it requires careful, multidisciplinary shared decision-making.
It's not a casual prescription.
No, you need the patient, the primary care professional, and the oncologist all on the exact same page.
And the reality is, even if the data says the systemic absorption is tiny, the psychological barrier for a survivor to put any form of estrogen back into their body is monumental.
It really is.
I know oncologists who strictly forbid it and patients who would rather endure the pain than take the risk.
And the guidelines are also very strict about other hormonal avenues. For example, they explicitly note that DHEA is contraindicated for breast cancer survivors.
Wait, really? Even though it's not estrogen?
Right, even though it's an adrenal steroid, it converts intracellularly into both estradiol and testosterone.
Oh, I see. Which leaves a massive population of patients completely stranded. They are refractory, meaning they get no relief from the non-hormonal sand watering, but they physically or psychologically cannot use the hormonal soil-changing treatments.
Exactly.
They desperately need actual structural tissue remodeling without using a single drop of estrogen.
And that profound, unanswered clinical need is exactly what has driven both doctors and patients to look outside traditional gynecology. They are looking toward the frontier of regenerative biomaterials.
Which brings us to the star of today's show.
Yes. The focal point of that frontier right now is the human amniotic membrane, which has quietly been producing some astounding results in complex surgical gynecology.
Let's get into the actual biology of this, because the research papers describing this material are wild. When we talk about the amniotic membrane, or AM, what are we physically dealing with?
The amniotic membrane is the innermost layer of the human placenta. It is the protective sac that surrounds the fetus during pregnancy.
Okay.
What makes it a true biological marvel, and why regenerative medicine is so obsessed with it, is its unique cellular makeup. Most importantly, it is completely non-immunogenic.
So it's a donor tissue, but the patient's body won't reject it like a transplanted organ or a foreign skin graft.
Correct. It naturally lacks complete HLA antigens.
HLA antigens.
Yeah, you can think of HLA antigens as the biological ID tags that sit on the surface of your cells. They are what allow your immune system to distinguish between what is you and what is a foreign invader.
Got it.
Because the amniotic membrane lacks a complete set of these tags, it can be implanted into virtually any human body, and the recipient's immune system simply ignores it. It acts as the ultimate stealthy biological bandage.
A bandage implies something passive, though. The sources describe it as actively commanding the surrounding tissue to heal.
It is highly active. When placed in a wound bed, the amniotic membrane secretes a complex matrix of growth factors. It naturally attracts collagen and fibrinogen to the site.
So it calls in the repair crew.
Exactly. It prevents cellular apoptosis, which is programmed cell death, keeping the local tissue alive. Furthermore, it actively inhibits inflammation and downregulates the cells that cause fibrosis or scarring.
I saw in the sources they're actually using this for a congenital condition where a patient doesn't even have a vaginal canal. How does that even work structurally?
You are referring to Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH.
Yes, that's the one.
It is a severe anomaly where a patient is born with vaginal agenesis. Surgeons have to physically create a cavity where none exists. Historically, they would use skin grafts to line this new cavity.
Which sounds painful.
It leaves terrible scarring and requires constant painful dilation.
And now they're using amniotic membranes instead.
They perform the vaginoplasty and line the newly created cavity with human amniotic membrane. The clinical results in the sources are stunning. They are creating 8 to 10 centimeter functional vaginal cavities.
Wow.
When they biopsy the tissue 8 weeks post-surgery, it shows normal, deep epithelialization. The patient's own cells have migrated across the amniotic scaffold and created healthy, normal mucosal tissue without rejection, without massive scarring, and without excessive dryness.
That is incredible. They're also using it to repair uterovesical fistulas, right? These abnormal, non-healing holes between the uterus and the bladder.
Yes, by applying fresh or frozen amniotic membrane over the defect, the tissue integration is so rapid that they're seeing a complete halt to urinary leakage within just 7 days.
But the absolute wildest application to me was fixing vaginal mesh erosions. We hear all these horror stories about synthetic surgical mesh used for prolapse cutting right through the vaginal wall.
It's a huge issue in gynecology.
It leaves these chronic, non-healing ulcers surrounded by dead, non-viable tissue.
It is a surgical nightmare to repair because the tissue around the exposed mesh is so compromised it can't heal itself.
Right.
The sources detail procedures where surgeons take an ultra-thick amniotic membrane graft and lay it directly over that exposed mesh in dead tissue.
And it works.
The membrane somehow covers the defect completely, encouraging the body to close the wound without prolonged scarring.
That is mind-blowing.
If we connect this to the bigger picture, what we are observing in all of these incredibly successful examples is the mechanism of action. The amniotic membrane, almost exclusively fresh or cryopreserved in these surgeries, is acting as a physical, biological scaffold.
A scaffold.
Right. It is bridging a structural, physical gap in a surgical repair. It provides a matrix for the patient's adjacent healthy cells to migrate across, while simultaneously secreting signaling factors that actively modify the pathophysiological process of wound healing.
It's providing the architecture and the blueprint for the body to fix a physical hole. And that brings us to the core mission of this deep dive.
The big question.
Exactly. If this material can help build a brand new vaginal cavity or heal a gaping ulcer over exposed mesh, can a dehydrated amniotic membrane allograft, or a liquid injection of it, safely regenerate and remodel atrophied, dry tissue in post-cancer patients?
To answer that, we have to look closely at the clinical guidance from the Women's Health Clinic. They release specific warnings regarding the use of these products for refractory vulvar conditions.
Okay.
Now, they specifically focus on a severe autoimmune condition called lichen sclerosus, which causes profound structural damage, scarring, and extreme dryness.
But the underlying principle, using an amniotic product to regenerate generalized damaged tissue, is the exact same concept as using it for post-cancer atrophy.
Exactly. And the clinic is unequivocal in their stance. They explicitly warn that claims regarding dehydrated human amniotic membrane allografts or injections must be framed with extreme caution.
So they aren't endorsing it.
Not at all. They classify the use of these products to promote spontaneous tissue regeneration in refractory disease as an evidence-limited regenerative concept.
Meaning there is no robust clinical data proving it actually works as a standard of care.
Far from it. They note that the marketing language surrounding tissue regeneration in these outpatient clinics often vastly outruns the actual clinical evidence.
I see.
Providers should not be promising symptom reversal, and they absolutely cannot guarantee structural tissue remodeling using these dehydrated products for this application.
Wait, you just walked me through a list of medical miracles. You told me it attracts collagen, prevents cell death, and heals completely dead tissue over mesh erosions. Here's where it gets really interesting. Okay, I'm ready.
Why is it suddenly evidence-limited the moment we talk about using a dehydrated graft to treat dryness or atrophy?
It comes down to two major scientific distinctions in the research: the context of the injury and the preservation of the material.
Walk me through the context of the injury first.
There is a fundamental biological difference between using an amniotic membrane to bridge a physical hole, like a surgical incision, a fistula, or a localized ulcer, versus injecting a liquid product into a widespread area of hormonally starved atrophic tissue.
So patching a localized traumatic wound is totally different than trying to wake up an entire region of tissue that is sleeping because it has no estrogen.
That is the crucial distinction. In the surgical cases we discussed, the amniotic membrane is giving healthy localized cells a physical bridge to cross so they can close a gap.
Right, the cells are already healthy. Yes. In the case of post-cancer atrophy, the cells aren't missing a physical bridge. They are missing their primary metabolic fuel, which is estrogen. The amniotic allograft, no matter how incredible, cannot replace the systemic hormonal signal that the entire vaginal ecosystem relies on to stay thick, elastic, and lubricated.
That makes total sense. You can't fix a systemic metabolic starvation problem with a localized structural patch.
Precisely.
What is the second distinction regarding the preservation?
The state of the material itself. The gynecological miracles in the research literature overwhelmingly utilized fresh or cryopreserved, meaning deeply frozen amniotic membrane.
So the cells are still viable.
Yes, this preserves the living cellular components. But for a product to be commercially viable for a local clinic to keep on a shelf and easily inject or apply, it goes through intense processing. It is sterilized, irradiated, and often lyophilized, which is freeze drying.
You have to dry it out so it doesn't spoil in a cardboard box in a clinic supply closet.
Precisely. And the dense research papers we reviewed explicitly note that these very processes of sterilization and preservation fundamentally alter the biophysical properties of the human amnion grafts.
You're saying the drying process destroys the magic?
It heavily degrades its regenerative efficacy. A dehydrated or irradiated graft does not behave biologically like a fresh living membrane.
It loses its power.
The delicate growth factors, the complex cytokines, the structural integrity of the extracellular matrix, they are severely compromised by the preservation process. Translating the success of a fresh surgical graft placed in an operating room to a dehydrated powder injected in a doctor's office is a massive leap in logic.
It's just not the same thing.
No, the current clinical evidence simply does not support it for reversing generalized tissue atrophy.
Well, if dehydrated amniotic allografts and injections aren't the magic bullet for post-cancer dryness, we need to talk about what actually is. Because if you are listening to this and you are dealing with refractory dryness, you need to know what can remodel tissue safely without estrogen.
What's fascinating here is that the most proven evidence-based alternative to biological grafts or hormonal creams isn't a chemical or a biologic at all. It is physical energy.
The sources dive into physical energy treatments, specifically highlighting fractional CO2 lasers. The Mona Lisa Touch system was designed specifically for genitourinary syndrome of menopause, particularly for breast cancer survivors who cannot take estrogen.
The clinical data supporting its efficacy for that specific population is very robust.
But on a purely intuitive level, shooting a hot laser into an intensely dry, atrophied, painful area sounds completely counterproductive. Why doesn't the heat just cause more damage and dryness?
Because it is all about the mechanism of controlled microtrauma. Instead of applying an external biological graft and hoping the body figures out what to do with it, the laser energy targets the atrophic vaginal mucosa and vaporizes tissue in a tiny fractionated pattern.
Vaporizes.
Yeah, it creates thousands of microscopic pinpricks of thermal damage, leaving healthy tissue in between.
You are intentionally injuring the tissue to force a reaction.
Yes. On a microscopic level, that precise thermal injury stimulates a massive, localized metabolic reaction. It triggers the body's innate wound healing cascade.
A wake-up call for the cells.
Exactly. It forces the local fibroblasts to wake up from their dormant state and initiate a process called neocollagenesis.
Which is the formation of brand new, healthy collagen.
Right. And simultaneously, it triggers increased vascularization, prompting the formation of new blood vessels.
Which brings more blood flow, more oxygen, and more natural fluid to the area. By causing that microtrauma, you are tricking the body into completely remodeling its own soil, making it thick and healthy again, without ever needing to add the estrogen fertilizer that feeds cancer.
It elegantly leverages the body's own localized healing response to reverse the atrophy.
Are there any other options?
Well, the sources briefly touch on a couple of other non-estrogen horizons being explored. There's a drug called ospemifene, which is an oral selective estrogen receptor modulator, or SERM.
How does that work?
It acts like estrogen specifically on the vaginal tissue, but the guidelines note it is still contraindicated if a patient is undergoing active breast cancer treatment.
So it's not a silver bullet either. The sources also mention early clinical trials looking at a patient's own adipose-derived mesenchymal stem cells, basically harvesting stem cells from their own body fat to treat female sexual dysfunction.
But again, much like the amniotic injections, extracting and injecting your own stem cells for vaginal atrophy is still residing entirely in the realm of experimental clinical trials, not standard outpatient practice.
Let's pull all this together. Post-cancer vaginal dryness is a severe, debilitating structural issue caused by a systemic lack of estrogen. And while the amniotic membrane is undeniably a miraculous, non-immunogenic tissue capable of healing severe surgical defects like fistulas or cavities, using dehydrated amniotic allografts or injections to regenerate refractory dry tissue remains an evidence-limited concept.
The science of dehydrating the grafts alters their efficacy. And the biology of bridging a structural surgical hole is entirely different from reversing hormonal starvation across an entire mucosal surface. Clinics should not be promising it as a cure.
Meanwhile, physical energy therapies like fractional CO2 lasers offer a proven, highly effective, hormone-free method for actual tissue remodeling. The takeaway for you, the listener, is that you do not have to settle for treatments like moisturizers that only offer temporary relief.
Nor should you feel pressured into expensive, unproven regenerative injections just because the clinic's marketing materials use buzzwords like stem cell or amniotic.
You have the right to demand evidence-based care tailored specifically to your oncology history.
I do want to leave you with a final thought to ponder. This goes slightly beyond the direct conclusions of the sources, but it builds on everything we've discussed regarding the future of this field.
Let's hear it.
We know from the clinical guidelines that automated microneedling can improve the delivery of topical drugs in severe vulvar conditions. We also know that lasers work by causing physical microtrauma to stimulate a healing response. And we know that fresh amniotic cells release incredibly powerful antifibrotic healing signals called exosomes.
Okay, I see the pieces coming together.
Could the future of post-cancer vaginal rejuvenation be a highly specific, synchronized hybrid approach?
A hybrid.
What if, instead of relying on a compromised, dehydrated allograft alone, regenerative medicine eventually combines the precise physical microtrauma of a CO2 laser with an immediate topical application of isolated, purified amniotic stem cell exosomes?
So the laser acts as the ultimate microneedling tool to prep the soil and trigger the fibroblasts, and then the purified amniotic exosomes are driven deep into the microchannels to supercharge the healing process without scarring.
Exactly.
You could theoretically force the tissue to regenerate completely, faster and thicker, without relying on systemic estrogen.
It is something to watch closely as the boundary between physical energy treatments and biological signaling continues to blur. That is where the next major breakthrough in survivorship care will likely happen.
Until that breakthrough arrives, remember that while you might not be able to safely add hormones to the soil and pouring water on the sand isn't enough, you absolutely have proven tools to fundamentally alter the landscape. You just need to know the science behind which tools actually work.